Well, hello. Isn't this great? Welcome, everybody, from all over. My favorite conference. It's been an absence in all of our lives, although we had an online conference last year. So some of the people you've seen on the small screen, you'll now see on the large screen in life in 3 dimensions and not virtual reality, and it's great. I'd like to acknowledge country before I go any further. The traditional custodians of the land here are the Ngunnawal people. I want to respect their continuing culture and the contribution they make to the life of this city and the region. And I'd like to welcome and acknowledge all other Aboriginal and Torres Strait Islander people here today. This is not a trivial acknowledgement in the 2.5 years that we've had up till now. Any pandemic in history has shown the fracture lines between disadvantaged communities and advantaged communities going right back to the Black Death. And in the first year of the pandemic, Aboriginal communities, with the help of the federal and state governments, and also, I think one of the good things that federal and state governments did do was kind of get out of the way, give support that they needed to control, because many communities were terrified that they would lose their elders. In the second year, it was almost inevitable, but it spread into particularly remote Aboriginal communities, but also Western New South Wales did it really hard too. And that's when community-controlled health organisations and many people in this room rose to the challenge to help control this virus in those communities. Community control is something that we can learn a lot from throughout the healthcare system. So 900 delegates, 90 partners and exhibitors, lots has happened. We've moved at COVID speed to change the way we do business. Are we still moving at COVID speed? Maybe not, but that's one of the things we'll explore in the conference. Just basic housekeeping. I think you can find the bathrooms for yourself. If you can't, you probably shouldn't be here. There is a designated speakers prep room, there's a parents room, and there is a prayer room on site for all delegates and guests. And if you need to know where they are, can't find them, please see the team at the reception desk who will help you. Evacuation procedures. If there's an alarm in the building, there'll be a beep beep sound, which just means the fire wardens will go off and investigate to see if there's something serious going on. Your sympathetic nervous system should be charged up if you hear a whoop whoop. And that there will be a recorded evacuation message. And we'll have to go to the designated assembly point, which is between the Crown Plaza, I don't know which way I'm pointing here actually, Crown Plaza Casino and Convention Centre. So if the front doors are nearest, you're going to have to go around the outside of the building to get to the evacuation point. RMA is continuing to go green with the conference app replacing a printed program. You can use the app to plan your personal agenda, receive notifications and updates from the conference team, share contacts by scanning your personal QR code within the app. Oh, that's why I'm getting contacting me. Okay, fine. Sorry if I haven't replied. Call me a boomer. And you can rate sessions and provide feedback. Now, there is a question and answer facility on the app. We haven't got, it's not activated yet. So for this particular session, when it comes to Q&A, which will be during Adam Coltzau's interview with Greg Hunt, we will take questions, but you'll either come to the, I'll explain it later, but come to the microphone or we'll pass a microphone to you. You've also got the opportunity to further engage in the conference by playing the RMA Zing game and collecting points or coins to win prizes such as RMA23 registration. That's the second prize. It's the first prize. The second prize is RMA23 and 24. You can get ACRRRM courses, discounts, heart sport rehabilitation products, sweet treats, gift packs, golf balls, and more. If you need assistance with the app, don't ask me. Go to the RMA registration desk or ask any of the conference crew who are wearing polo tops with the RMA22 Aboriginal artwork, which is designed by local artist Richard Allen Jr. The conference theme is bold, boundless, beyond together, covering topics such as celebrating and leading change for improved rural health outcomes, innovative rural solutions for busy clinicians and practices, advancing rural specialist knowledge and skill set, recognizing the importance of clinician and community well-being. It includes specially designed content for doctors in training and future rural generalists. And one of the great things about last night was just seeing how many rural generalists in training are actually here today, and it's just fabulous. And it is such, I'm a signed up fan, having been at the original meeting which set up the Rural Generalist Programme in Roma, and I've been utterly committed to rural journalism since. And these sessions will be chaired by representatives from the ACRRRM Registrar and Future Gens committees. The programme is also full of opportunities for connection and networking, lots of social functions to choose from. Your RSVP to social functions and bus transfers has been noted on your lanyard, which is your ticket into all events. Conference awards, dinner tickets cannot be swapped or modified in any way. The final guest list was given to Parliament House security staff last week, and no changes can be accommodated to security protocols. Please speak to the registration desk team if you have any concerns or questions about this fully sold out event. It now gives me great pleasure to introduce RDAA President Megan Belot to welcome you.
Thanks, Norman. Before I start, I'd like to acknowledge the traditional custodians of the land on which we meet today, the Ngunnawal people, and pay my respects to their elders, past, present and emerging, and to all the Aboriginal and Torres Strait Islander people in the room today. As I said last evening, it's great to be able to come together in person to reconnect and re-energise. I'd also like to acknowledge our colleagues who have remained in our communities, enabling us to come to Canberra for RMA22. A big thanks to the team who've pulled together a program that has something for everyone and lots of opportunities to network and socialise. Please take the time to visit the trade and talk with our conference partner representatives, as this event would not be possible without them. You'll get to hear my formal address to delegates tomorrow, so I'll keep it short and sweet for now, and I really hope you enjoy RMA22, and as Bluey would say, for real life.
ACRRRM and RDAA wish to sincerely thank all partners for investing their time, support and continued commitment to RMA22. Their generosity and backing has helped the team put on this event for you, all whilst keeping tickets flat again this year. RMA22 sponsorship has meant an event with 13 networking functions, the first RMA Wellness Centre, which includes opportunities to relax and unwind throughout the event, over 100 academic presentations and more than 20 keynote speakers. It gives me great pleasure to introduce Defence Force Recruiting, who is a platinum partner of RMA22. It takes a very special team of qualified healthcare professionals to support the health and fitness of over 70,000 members of the Australian Defence Force. Defence Force Recruiting ensures that this team of qualified professionals are on hand to support ADF efforts both domestically and operationally, and we're living in a time where that's needed probably more than any other since the Second World War in Australian history. Please welcome Squadron Leader Raelene Lahiff.
Good morning, ladies and gentlemen. My name is Raelene Lahiff. I'm a nursing officer, registered nurse in the Royal Australian Air Force. And on behalf of Defence Force Recruiting, I would like to begin by expressing my sincere thanks and gratitude to the Ngunnawal people, the traditional custodians of the beautiful land on which we have joined to meet, learn and connect today. I would also like to pay my respects to their elders past and present, and to the Aboriginal and Torres Strait Islander men and women who have contributed to the defence of Australia in times of peace and war. I'd also like to thank the Australian College of Rural and Remote Medicine and the Rural Doctors Association of Australia for allowing Defence Force Recruiting the honour of being Platinum Partners of RMA22. Defence Force recruiting is entrusted to recruit the next generation of Australian women and men into the Australian Defence Force. The Australian Defence Force is a modern, dynamic, supportive and people-focused organisation comprising of the Navy, Army and Air Force. We offer hundreds of roles and are committed to equality, diversity and inclusion in our workplaces. We are entrusted to defend our nation, people, borders and way of life. We help communities affected by conflict or natural disasters and support our allies through international operations. As clinicians in the Australian Defence Force, our role is first and foremost to deliver quality, safe, efficient and effective healthcare to our fellow Australian Defence Force members. We are our colleagues' safety net that enables them to do the dangerous and often challenging work that they do in remote and austere conditions. But they do this safe with the knowledge that we are there to look after them if they are injured or ill. Our work also extends to supporting communities both within Australia and overseas. The 20th anniversary of the horrific Bali bombings yesterday is a reminder of the agility and speed in which the Australian Defence Force can act, given that within 36 hours of the bombings, 34 ADF doctors, nurses and medics from both our permanent and reserve forces evacuated 66 patients out of Bali on 5 RAF C-130 Hercules aircraft, a staggering effort that undoubtedly saved lives. Doctors in the Australian Defence Force get to work in a variety of interesting, challenging and rewarding places, be that in the middle of the ocean on one of our ships, providing healthcare to patients at 38,000 feet in the back of an aircraft, outfield in tents, or delivering healthcare to our defence members on our bases. Much like rural and remote medicine, military medicine is as complex as it is varied. A mixture of primary healthcare, occupational medicine, population health, aviation and underwater medicine, mental health, emergency medicine, and this is why many of our doctors undertake fellowship training with ACRRRM. So please drop by our stand if you'd like to learn more about working as a doctor in the Australian Defence Force in either a full-time or part-time capacity. And for those under the age of 60, I'm here to let you know that you can join as a reservist prior to your 60th birthday. For those currently studying medicine, please come and chat with us about our Defence University sponsorship opportunities. These are fantastic opportunities where Defence pays you a salary to study, your degree is paid for up to the Commonwealth supported amount, and as a full-time member of Defence, you're entitled to leave, housing and dental benefits, along with an attractive superannuation package. But that aside, you will be provided with fantastic training and opportunities throughout your career. Myself and my Defence Force colleagues, Kate, a registered nurse in the Navy, and Rosalie, would love to meet with you. We've also been joined by many of our colleagues, our uniformed doctors, who are here easily identifiable in uniform, and they're more than willing to talk about their experiences during their time in Defence. Lieutenant Commander Jessica Webster, one of our esteemed Navy doctors, will be delivering the Lunch and Learn session on Saturday, so please join her while she talks about her work as a GP in the Navy at sea. Ladies and gentlemen, on behalf of Defence Force Recruiting, I thank you for your time and also thank you for the amazing work that you all do in service to our remote and rural communities. Enjoy the conference.
Thank you, Raelene. Important work. Emma McBride is the Federal Member for Dobell on the Central Coast of New South Wales. Is now the Assistant Minister for Mental Health and Suicide Prevention and the Assistant Minister for Rural and Regional Health. Minister McBride can't be with us in person today, but she has recorded a short message for us.
Hi, I'm Emma McBride, Assistant Minister for Rural and Regional Health and Assistant Minister for Mental Health and Suicide Prevention. Thank you so much for inviting me to speak with you all today. I pass on my apologies that I can't be with you in person, as I'm joining the 4th World Health Organization Global Mental Health Summit. While Dr. Brendan Murphy has kindly agreed to deliver a speech on my behalf, I'd like to reiterate my thanks for the work you do, providing vital care and support to rural and regional Australians. It's never been harder to access medical care than it is right now. The conference theme this year, Bold, Boundless, Beyond Together, emphasises the need to be brave and innovative and work together to find solutions. I'm keen to hear about the outcomes of the proceedings and look forward to continuing to working with all of you into the future. Thank you and congratulations.
Thank you very much. Before I introduce Sarah Chalmers, I just want to sort of make a personal note here. When ACRRRM was created many years ago now, I was one of the skeptics. Like, why do we need a new college? And I was very rapidly convinced of the value of having a College of Rural and Remote Medicine. And it has been a trailblazer in terms of rural medicine. It's been a game changer. For my sins, many years ago, I chaired the GP MOU group, and there are people in this room who remember the GP MOU group. So this was an attempt to get the warring groups in general practice together to come to agree on reform. It was a complete nightmare, I have to say. The AMA was supposed to be part of it, but it sat outside and kind of beamed in messages. This is before texting, I think. And but the only actual practical contribution was actually made by the RDAA, and this was before the ACRRRM was created. In ACRRRM, you have, my observation is, you have a pragmatic college which wants to get on with stuff in the way that rural, regional, and remote practitioners do, find practical solutions. And I suppose what I hoped from ACRRRM through the years was that the College of GPs would actually see what ACRRRM was doing and learn from it. Hasn't happened yet. Hopefully it will. When Adam's speaking to Greg, I would be interested. I mean, I think it was some source of great frustration to the previous government that they were ambushed a few weeks before the budget in terms of the 10-year plan. So ACRRRM is a really important part of the health and medical landscape in Australia. And so it gives me great pleasure that the opening address now is from the ACRRRM President, Sarah Chalmers, who works in East Arnhem Land and has done for 15 years, did so for 15 years before moving to Northern Queensland in 2019. Private general practice, hospitals, remote Aboriginal communities and homelands in the Northern Territory, part of her experience, and now working as a rural generalist in Winton in Western Queensland. Her clinical interests include remote practice, Aboriginal and Torres Strait Islander health, occupational health, and sports medicine. Please welcome Sarah Chalmers.
I'd like to start by paying my respects to the Ngunnawal peoples, the traditional owners of the lands where we meet today. And I pay my respects to their elders, past, present and emerging. And I extend the respect to all Aboriginal and Torres Strait Islanders who have joined us here today. Welcome to RMA. And I'm so excited to be saying that. I've actually locked my family up for the last 2 weeks, just in case one of them came in contact with someone who had COVID. There was absolutely no way that I was going to miss the conference. I did let them out just before I got on the plane on the way here. So on that, I would like to, Megan's mentioned that there are some of our colleagues who have stayed at home to continue to provide medical care for our rural and remote communities. And I'd like to send a shout out to them, but also to, when I mentioned COVID, there probably are some people who at the last minute haven't been able to come because they've developed some symptoms. So I hope everyone gets better quickly. So this is a little bit weird because today is a really big day for me. This is the first time I've had the opportunity to give an RMA plenary as the ACRRRM President. But about 4 o'clock this afternoon, I'm actually stepping down as President. So I feel like I'm doing it all in one day. I suppose I have to take a little bit of time. Normally, I would have done this a couple of years ago, just introduce myself to you, and thanks Norman for some of the stats from my bio. So, I'm a rural generalist and I spent most of my clinical career in Arnhem Land, but I also have worked in some other really cool places. So I worked in Tennant Creek at the hospital in the general practice. I've worked on Palm Island. I did work in Winton. I've stopped doing that now. I work for James Cook University, which is an amazing institution, and I think there's lots of graduates of both the JCU medical program and the general practice training program here today. Something you might not know about me is that I'm an ACRRM legacy, as in I'm a second generation FACRRM, and we're a pretty small privileged bunch, who grew up knowing that rural generalism was a real thing and that it was a career. And we have, there were some not so good bits about it. My mum and dad were forever cranky, fighting hard, as many of you in the room did, 25 years ago, trying to put ACRRM together. And we're so very grateful for everybody who participated in that, because 25 years down the track, this is an incredible organisation, and alongside, those warriors from the early days of the RDAA, I think on behalf of all, doctors who got to train directly towards their FACRRM over the last 25 years, we're really, really grateful for all the hard work that you did. Thank you. And obviously, like everyone in the room, I find RMA to be an absolute highlight of the year. So I'm just going to say one more time that the last couple of years were really, really crap. Absolute rubbish. And as a consequence, I missed being here. I missed being back with my colleagues, my friends, my tribe, I think, as Ruth Stewart said a couple of years ago. So it is fabulous to be here. Because RMA is a little bit like a family reunion. There are so many colleagues that I've met over the years. There's people here that I went to medical school with. There's people who taught me at medical school. Some of my junior doctor friends are here, and actually some of them I flattered with as well. There's lots of amazing work colleagues. There's the person who gave me my first academic position, and people who mentored me through, the early days of my academic career. There's lots of my amazing work colleagues and some registrars that I've helped to train as well. And actually there's also a handful of people that I've only ever met at RMA, because I've never worked in New South Wales or Victoria. And I know for many of us last night was just a lot of squealing and a lot of big hugs, and it was just a really positive place to be. 2 years as ACRRM President's been quite a ride, and I thought I'd talk about some of the things that I've learned, and I'm going to try and use the conference themes as a guide. So first up, bold. So I thought I was pretty bold putting in my nomination to be ACRRM President, and I still sometimes find it hard to believe that I got the gig. And it was actually one of the hardest things that I've ever done. This might be the second one. But what I've learned is that, once you make one big bold decision, then the next few bold decisions don't seem quite as difficult. But rural generalists are bold. They're very bold people, and when I was thinking about this and talking to a colleague, and she reminded me about, that one of the things that we have as rural generalists is clinical courage. That's our boldness. Previous President Ewan McPhee is a bit of a Star Wars fan, so it made me think that we could think of clinical courage as our force. And so, as rural generalists, we, bring out our inner Yoda when we're out in the middle of nowhere, not really sure just exactly what someone else would do, in this particular situation, but you're the one who's there in that place at that time with that patient who has a problem that you need to solve. A colleague once said to me, look, it's not going to be pretty, but we'll get this person to an emergency department still alive. And that's what we do as rural generalists. It's not always the way that everybody else does it, but we do it with the resources that we have at the time, and that's one of the ways that we help to save patients' lives and provide excellent care in rural and remote Australia. Sorry, losing my train. So I actually think what would be really great in the future is that along with teaching clinical reasoning at medical school, that we start teaching about clinical courage, about how to take risks, safely, of course, considered risk, and that might help more people to move outside of the hospital system and take on the joy of primary care, general practice, and particularly in a rural and remote area. So the next theme is boundless. And, the scope of a rural generalist is as broad as the community where they work needs them to be. Rural generalists are currently bucking the medical trend by embracing generalism to its extremes, and it is quite incredible to watch. And if you need examples of this, I think the best one would be the Antarctica project, but actually there's a whole bunch of them across the country. So rural generalist medicine has become boundless. So, and I think thanks to ACRRRM and RDAA. So, we're looking at a national pathway for rural generalist practice, and all of the states are implementing their programs and looking at how to build their careers, build the rural generalist career into their current structures. Admittedly, some are doing it better than others. Medical students are looking at rural generalism as a career, and the latest MSOD report actually for the first time included rural generalism as a choice. And even though we would like there to be more people choosing general practice and rural generalism as a career, a quarter of the students who said that they were interested in primary care actually said that they wanted to be rural generalists, and I think that's quite an incredible achievement. I guess something else that's boundless that I have really enjoyed in the rural medical space in the last couple of years is women in leadership. And ACRRRM is one of the few organisations that has had nearly a third of its presidents as women. But in the last 12 months, leadership in ACRRRM has included, as women, the President, the CEO, the chairs of the Registrar Committee, the Future Generalists, and the Clinical Council. I know, amazing, hey? And over the last 12 months, I've also had the amazing privilege of, standing alongside Dr. Belot. So 2 women in rural and remote medical leadership I think, is also quite an achievement. But always, we've still got a long way to go. So that's, one tick for gender balance. The next box to tick to make sure that we've got leaders in our space, is with Aboriginal and Torres Strait Islander leaders. And we have a number of amazing individuals in our college and our organisations. And I'm looking forward to the day when one of them is actually standing where I am right now. And I guess the other thing would be international medical graduates. They're an incredible part of our profession, and it'd be great to see them in some leadership roles as well. So beyond, where do we go from here? It's always onwards and upwards. So as I mentioned, there's been a bit of talk about general practice and primary care lately. And the word crisis and broken, they're being thrown around like there's no tomorrow. And there's no question that it is quite a tough environment out there. But it's worth noting that ACRRM continues to buck the trend. So, and I think that we should all be proud of what we're achieving and use our success to demonstrate to government that we do have the solutions and we know how to keep us moving forward. We can solve our workforce shortages and ultimately continue to improve access to quality primary and secondary care for all rural and remote communities across Australia. And let's face it, you know, when we're talking about being bold, I think it's already been mentioned, but the government needs a hand to be bold and courageous, to make the big decisions that we know will lead to the solutions for better primary health care across the country. We know an awful lot about what doesn't work, because that's what we have right now. But equally, I think that rural doctors, you know, we know the solutions for rural Australia. We don't need urban solutions for our problems. We need to be able to work this through ourselves. I'm not going to go through the list. I think it was published by the UN in 2010 or something like that. You know, we just need to go back to that document and keep working through the list. And I am very confident that, you know, having achieved everything that we have in the last 25 years, that the next 25 years are going to be a really incredible time, and the health of rural and remote Australians is going to look very different in 25 years. So I'd like to take a short moment to thank everyone that I've actually had the privilege to work with over the last 2 years. It's been a pretty amazing time. There's been good days and bad days, of course. But if there's anyone out there who's thinking, I wonder if I could do that, I wonder if I could be the ACRRM president, you definitely can. And if anyone's got any questions, I'll be hanging out down there after the plenary session this morning, and I'd love to speak to anybody who has aspirations for leadership. Finally, thank you all for listening, and I hope you have an absolutely wonderful conference. I know I will. Thanks.
Thanks, Sarah. Enjoy your last few hours in the role. We're living in a time of a policy vortex. I mean, who would be a bureaucrat in today's governments around the world as the pandemic continues? Uncertainty, the community looking to themselves, thinking about how life has changed for them, people in professional roles rethinking them, thinking about lifestyle and so on. And we're also, it's highlighted, as I said earlier, the fractures in the community. The pandemic has done that as well. So we've moved forward at speed to a situation where there are multiple serious issues running. I mean, the interesting political issue is often about healthcare reform, and it's a bit like healthcare reform is, and Greg may disagree with this when he talks to Adam, but and Ruston may too in a moment, but healthcare reform is hard. So it's unlikely that Lyndon B. Johnson could have gone to China and had the impact that Nixon had. It took Nixon because the opposition was going to come from the right and the Republicans in Congress. So it took Nixon to do that. It took Menachem Begin from the right of Israeli politics to make peace with Sadat, Anwar Sadat. And in some ways, it's in Labour's lane to reform because Medicare is seen as their baby. And the question at the moment really is, do they have what it takes to reform in the way that it needs to be? Medicare is broken and not fit for purpose. I think there's wide agreement about that. The question is, what comes next? This conference is an important time for you to talk to each other because what's needed is a single voice rather than the plethora of voices that we've had to see how we can get consistent reform. And the person with the unenviable task of marshalling these policies together, bringing them together as a strong independent bureaucracy to provide advice to government is Professor Brendan Murphy, who commenced the job as Secretary of the Department of Health 13th of July 2020 after this really relaxing job that he had before that as Chief Medical Officer in the face of the pandemic, along with Greg Hunt and the Prime Minister, then Prime Minister Scott Morrison, and marshalling us through those first 6 months of the pandemic before handing over to Paul Kelly, but also having a very significant role after that. And now there are multiple issues going forward: the future of rural journalism, the workforce, the future of Medicare, as well as the routine work of the department. So it's going to be fascinating to hear from Brendan Murphy. Please welcome him.
Thanks very much, Norman. Before I begin, I'd like to also acknowledge the traditional owners of the land on which we meet, the Ngunnawal people. I'm here today representing Assistant Minister McBride, Assistant Minister for Mental Health and Assistant Minister for Rural and Regional Health, and she was devastated that she couldn't be here in person, but as you heard from her video, she has a very important international mental health engagement. I would like to acknowledge at the start Belot, President of RDAA, Sarah Chalmers, President of ACRRRM, our very own Ruth Stewart, Rural Health Commissioner, Simone Ray, AIDA President, Senator the Honourable Anne Ruston, Shadow Minister for Health and Aged Care, and someone I have met once before, the Honourable Greg Hunt, former Minister for Health and Aged Care, and probably the person I blame for now doing this job rather than the cushy CMO job. There are many, many other distinguished guests here today, and this exciting room full of people dedicated to one cause: improving access to and quality of rural and regional health. It is hard to think of a more important issue than this in the current healthcare environment. As Sarah said, there has been much in recent media of public narrative in recent weeks about the challenges generally facing primary care in Australia and the attraction and retention of health professionals into primary care. These challenges, as you all know, are much, much more evident in rural Australia, where the primary care business models of the past are simply not sustainable now in many settings. But rural health is, of course, much more than just primary care. Access to specialist care and high quality and accessible hospital care, including the crucial emergency and maternity services, are also significant ongoing challenges for those 30% of Australians who live outside the major cities. I think it is important to reflect that the fact that we do, as a nation, continue to provide, in nearly all cases, high quality care for this population, despite the many challenges, is an extraordinary credit to the efforts, innovation and commitment of the people in this room. So aptly reflected in the theme of your conference, Bold, Boundless, Beyond, Together. You should be extraordinarily proud of what you continue to achieve and the quality of care you continue to deliver in some quite difficult and very challenging circumstances. We have all been working on the challenges of rural and regional health for many years, across governments, professional groups, community and more. There has been a lot of innovation, many programs, many levers and incentives tried, some more effective than others. But clearly more is needed, including ensuring that a rural and regional lens is absolutely front and centre of all of our health workforce strategies and all of our work in primary care and hospital reform. For example, our National Medical Workforce Strategy, a document that I have some personal ownership of, which is now being implemented as a major priority. It has a significant focus on substantially boosting the number of doctors choosing general practice. But it will not succeed as a strategy if those new GPs are not also prioritised and incentivised to work in rural and regional Australia. We're in the final stages of the transition of GP training to the colleges. Again, an absolutely paramount objective in this transition is to ensure that the primacy of rural training and rural experience is maintained. I would like, on that note, to pay particular credit to the huge role of GP registrars who have played an extraordinary and disproportionate clinical role in meeting the clinical needs of rural and regional Australia. They have been a backbone of our rural and regional primary care workforce. The same rural lens is obviously needed in our nursing strategies, which are under development, and our future approach to allied health. One of the most frustrating things for me in the workforce dimension of the rural health challenge is to get that message out there to current and future health workforce about just how rewarding is a health career in rural and regional areas. The broad scope of practice, the variety of clinical work, the strong sense of community connection. If I were a GP or a general surgeon or a primary care nurse or an allied health practitioner, I genuinely believe that those positive aspects of rural health would more than compensate for the many undoubted frustrations of working in a rural setting. There is no doubt in my mind that part of the challenge is in fact marketing, and more importantly, that experiential immersion in rural health that we all know leads to people acquiring the passion. I have alluded to the many strategies that have been employed over many years to address the rural health challenge, and the government is now building on these and carefully evaluating them to work out which ones have worked, which ones should grow, which ones to consolidate, and which pilots of the many pilots should be mainstreamed and expanded. There are many, many innovative ideas which have been around and are being tested, often needing tailoring to unique geographic circumstances. One of the key principles, particularly in more remote settings, has been to consolidate the resources of the Commonwealth, the states and territories and the private sector in the delivery of care in thin markets. The Commonwealth has just renewed the Memorandum of Understanding with the states and the Northern Territory to continue access to Medicare billing at approved hospitals and health services in rural and remote Australia. This allows doctors, nurse practitioners, midwives and allied health practitioners working in rural and remote locations and hospitals to bulk bill Medicare for eligible primary care services whilst in salaried employment. These collaborative arrangements have also recently been expanded significantly in other settings where innovative models of employment in primary care are being piloted in places where the traditional private practice model has clearly now failed. A similar pooled funding initiative is being employed in the Murrumbidgee region for GP registrars, with significant positive reports now from registrars in that training program. The government has also recently committed $146 million in election commitments, progressively now being implemented to boost rural healthcare. These include expanding those innovative models of care program pilots to new areas and providing additional training posts for rural generalist registrars, rural GP registrars and fallowed rural GPs to take up the opportunity of advanced skills training, a crucial part of the training of rural generalists. One of the key lessons of recent years has been the critical importance of training and experience in a rural setting. We know that rural origin students and those students and health professionals whose undergraduate and postgraduate training occurs principally in rural locations often choose to stay and work there. A particular gap in recent times has been to provide that early postgraduate experience for young doctors in rural general practice. To address this, the government is further increasing junior doctor rotations to more than 1,000 placements under the John Flynn Pre-Vocational Doctor Placement Program by 2026. This will encourage more hospital-based doctors to experience the true joy of rural general practice and to develop the passion for this vocation. The government is also committed to boosting the workforce incentive program to even better support multidisciplinary care in primary care in rural areas. Of course, we cannot fix rural primary care without broader consideration of the global issues facing primary care in Australia. Incentives, experience and loadings will help people choose a rural location, but first and foremost, we want health professionals to choose a primary care career. A major plank of the new government's agenda is strengthening primary care and reinvesting in primary care and building on the 10-year primary care plan. Minister Butler is personally chairing the Strengthening Medicare Task Force and is committed to implementing the 10-year primary care plan. $750 million has been committed to deliver high-priority investments in primary care, in addition to a significant program of capital grants to upgrade primary care facilities and the establishment of 50 primary care urgent care clinics. This is on top of significant new investment in primary care as part of the COVID response in recent years, such as long-term telehealth. The Strengthening Medicare Task Force will provide concrete recommendations to government by the end of 2022, and there's been very strong and wide sector engagement so far, including from people here today such as Sarah Chalmers and Ruth Stewart. Other important initiatives from government include a range of important rural health capital investments. We are also in the department reviewing our specialist training program to ensure that its primary goal to promote both underserved specialties and underserved rural training locations are appropriately met. I mentioned earlier the National Medical Workforce Strategy, which is now being implemented nationally and has a strong focus on rural health. Our new National Nursing Workforce Strategy is underway and will similarly emphasise the crucial role of nursing in meeting rural healthcare needs, including primary care. There is also much innovation underway in the allied health workforce. Look at the huge role pharmacists played in COVID-19 vaccination, particularly in rural areas, in mental health workforce and in the crucial care work. So much is happening and so much to be done. So I look forward to hearing about the outcomes of this exciting conference and continuing discussions with RDAA and ACRRM and the many other players in this room and in the rural health ecosystem generally. Happy 21st birthday, ACRRM, and thank you for your attention.
Want to take a couple of questions?
Yeah, sure.
So can we talk about incentives? I mean, one of the issues with the 10-year plan, it's good to hear that it's still in play, is that I think Steve and Wally were talking about reinvesting the incentives into practices rather than into physicians' pockets. But there is a problem there. You know, kids coming out of medical school look at what you can earn and say, well, whether it's rural or regional, say it's not enough. What incentives beyond the 10-year plan are you looking at to get kids to go into rural or even just general practice itself?
Yeah, I think, Norman, we all have to agree that there is a disparity between the income of GP specialists and non-GP specialists. Now, and somehow or other we have to try and address that. So there is always been in the incentive space a mixture between practice incentives, which are part of the workforce incentives program promoting multidisciplinary care, but also increasingly we are looking at how we can use service incentive, so payments that actually will go to the doctor, because we do have to try and address that income disparity. It's not going to be something that's readily doable. I think one of the challenges is this very active debate. There are some people who say the best way to fix general practice is just to increase the MBS rate significantly. There's not clear evidence that would promote quality of care.
Doesn't get to a new place.
It doesn't get us to a new place, whereas, but having said that, you can't only fix general practice by funding more primary care nurses, more primary allied health. We have to do things that will also support the income of primary care physicians progressively.
How open are you to disruptive models?
Look, I think, obviously those are decisions of government, but my sense from Minister Butler is that the reason he's chairing this Strengthening Medicare Task Force is that he has, and those who've been with him in those rooms, I haven't been there, will attest to the fact that he is really quite interested in exploring innovative models. Now, the challenge with very disruptive models is you get there's often a reaction, and government has to then have the courage to see through some of the vested interests that might be against their action. But I don't get a sense that Minister Butler personally is frightened of having some disruption.
How are you going to encourage the other specialist colleges to train rurally remotely.
Yeah.
I mean, there was a huge problem with the College of Surgeons in Queensland that they were really focused in South East and not in far North Queensland, for example.
Well, so that's a key part of the National Medical Workforce Strategy. We've got to stop training specialists we don't need in big city hospitals. We don't need...
You're playing to the choir here.
We don't need to train 6 orthopaedic registrars at Austin Health, where I was CEO. We don't need them in Melbourne. If you want to be an orthopaedic registrar, what we have to do is make sure that many or a lot of the training positions are actually in rural and regional areas. So if you want to be an orthopaedic surgeon, you've got to go rural or regional.
But what can you do about that?
Well, that's the whole part of implementing the medical workforce strategy. So I'm working with my state and territory health CEO colleagues to say, you have to staff your hospitals in a different way. Austin Health has to staff its orthopaedic department with a mixture of career medical officers, various other professions. You cannot have your service workforce inevitably be linked to training outcomes. So, and then the other part of it is the colleges have to be much more flexible about their rural training accreditation. They can't be so precious to say you've got to have 1.5 EFT of consultants, a secretary and a computer to be a registrar. So, and that they are open to that. They say they are.
You're going to get carried out on the shoulders of the...
Yeah.
So, rural generalist pathway. Previous government put a lot of money into it.
Yeah.
Arguably, some people would argue not enough, but it's a lot of money that wasn't there before. And it still seems to be going very slowly.
Yeah.
How do we speed it up? What are the blocks? I mean, Ruth Stewart's talking tomorrow, but let's start talking.
Yeah, look, I think I'm quite excited about the transition to college training. I think ACRRRM have embraced this transition to training, and I think that will help to make rural generalist training much more attractive. We've got to do more in investing in those advanced skills places. We've got to provide those training opportunities to get the advanced skills, and that's certainly something that's part of the election commitments.
But some states aren't playing ball, particularly with the state awards.
Yeah, well, and I think that's absolutely something we're working with the State and Territory College. We have set up a rural generalist unit now. The Commonwealth has funded this in every state and territory health department, a coordination unit, and we now have to work with those industrial issues as well. And that's an active discussion at the health CEO's level.
Do you miss the passing of Health Workforce Australia? Having a semi-independent group doing analysis for you?
Look, I think I was acting chair of the board of Health Workforce Australia at some stage, so I did.
Now you'll get boos from the audience.
It did have the benefit of a single point of data analysis focus, and so we probably had better data then. Now we're trying to replicate a lot of that in the department. We now have extraordinarily good, sophisticated primary care data, which is interactive, and we're trying to develop that for all of the other medical specialties. But I think we have replicated some of that, but there's no doubt that one of the current challenges in the health workforce space is that bringing together the disparate data sets from the Commonwealth and states is a challenge.
Ladies and gentlemen, please thank Brendan Murphy. The Shadow Minister for Health is Senator the Honourable Anne Ruston, who is also Minister for Sport, Manager of Opposition Business in the Senate. Born and raised in Renmark on the River Murray in South Australia, and continues to have a strong connection with the Riverland community, and the Riverland community is very significant in terms of rural training, particularly for medical students. Really pioneered that in Australia along with James Cook. And she is passionate about regional South Australia, and the only South Australian senator who maintains a regional electoral office. Really? That's terrible. I mean, it's good that you're doing it, terrible that you're the only one. Please welcome Anne Ruston.
Thank you very much, Norman. Can I too acknowledge the Ngunnawal people, the traditional owners of the lands on which we meet today, and pay my respects to elders past and present, and also extend that respect to any Aboriginal or Torres Strait Islander people that are in the room with us today. Can I acknowledge our distinguished guests here, Sarah Chalmers, Megan Belot, Ruth Stewart, Dr. Murphy. And on indulgence, can I also acknowledge my very dear friend and colleague, Greg Hunt, who I think single-handedly probably did more to support Australia through the pandemic as one person than anybody else in Australia. So firstly, can I thank the college and the rural doctors for the opportunity to be here today, an opportunity to introduce myself to those of you who I have not met before, and to probably extend my thanks to those of you who have patiently tried to take me through all things rural and regional health. As the novice on the block, it has been really greatly appreciated, and it's really fantastic that we're all actually able to be here in person for the first time since 2019. Can I take this opportunity to acknowledge what you did during the pandemic? The last 3 years have been extraordinary, and I think it was, in Sarah's words, it's been pretty crap. And to you, thank you so much for what you did for Australians, for what you did for Australians in rural and regional areas, the untold number of lives that you probably saved by your innovative approach, your tireless work during that time cannot be underestimated, and I think Australians all owe you a huge debt of gratitude for what you did during that time. So a serious thank you. I also thought, one of the pillars that you have today for your conference was extremely timely, and that was the pillar of together. I don't think there can be a more important time that we address and focus on things like the well-being of our communities, making sure that mental health is at the top of mind, self-care, and particularly making sure that we are nurturing our workforce, because it has been tough, and now is the time to make sure that we're looking after each other so that we can pick ourselves up and move on, because the challenges certainly haven't gone away. Because as I said, the pandemic is far from over, but the challenges are far from over. And in rural and remote Australia, access to workforce clearly is the #1 issue that is before us right now. And that's why I think it is just so terribly important that we all work together with you as the frontline experts to make sure that we understand what is happening out there on the front line. And no one is better placed than the people that sit in this room to inform what those decisions need to do. Because to a large extent, I think that rural and remote Australia and general practice is really the canary in the coal mine. And you're where we see the stress first. And I'd like to suggest that maybe policymakers and bureaucrats could maybe look to rural and regional Australia to actually perhaps get a bit of a heads up and an earlier sign about some of the things that need to change before we see the kind of chronic situation that we are seeing now in relation to workforce. But by way of introduction, as Norman said, born and raised in a little town called Renmark in the Riverland. My mum was a nurse, and community care was sort of just the way things were done back then. And at the heart of that community care approach was just getting on with it, everybody working together and everyone looking out for each other. The pharmacist had dropped past the nursing home on his way home from work to drop the medicines in for the residents. The doctors just saw the nursing home was just an extension of their hospital rounds, and after hours and home visits were, just the norm. I think these days they call it a multidisciplinary approach to care, but back then that was just how it was done, and I'm sure for many of you in rural and remote Australia, that's just the way it's still done now. And so it's on this platform of a long-term interest in community-led care. I also sat on my local advisory health council prior to joining the Parliament, which had oversight of our local aged care facility and hospital back in Renmark. And I think there were a few things that time really taught me, and I'm interested to hear whether you think this is still the case, not that it was that long ago, but these experiences really highlighted to me how important the local hospital is to the attraction and retention of GPs into the community, how important GPs are to the vibrancy of a local community, how important the permanent relationship between the patient and your GP is, and how strong community involvement and ownership of health outcomes can improve the outcomes for the entire community and deliver real benefits. So I don't think anyone would disagree that general practice is the foundation of Australia's health system, sort of the shop front for primary care, I suppose. And the sustainability of our healthcare system must also be based not just on primary care, but a good dose of preventative healthcare as well. I'd love to convince governments that good health should be seen as a long-term economic investment and not just a cost centre. I would like to convince Treasury that avoided costs are actually real and should be booked to the budget. I want to better understand how we can reduce the burden on our health system through these preventative measures, because I genuinely believe that the sustainability of our health and our aged care sectors can only be guaranteed if we actually focus on avoidable interactions with it. We've got to turn our health system into one that focuses on good health and not one that's just designed to respond to disease and illness. And general practice, I genuinely believe, is the heart of good health. But right now, general practice is facing huge challenges, and clearly that could not be more evident than it is in rural and regional communities. Clearly, the levers that are in place at the moment to make GP practice in the bush an attractive decision for medical graduates clearly isn't working. And sadly, over time, I think the idea of being a GP instead of choosing alternative specialist pathways is one that appears to have been devalued in the minds of Australians, despite what you would clearly know is an extraordinarily rewarding career to be pursuing as the frontline people in primary care. So I'm keen to really explore how we can do things like better exposure of our graduates and our medical students to the really exciting and diverse experience that they could have as a rural and regional generalist, so that they will choose, or at least be able to see what the opportunities are for them when they decide when they choose their specialty, and hopefully they'll choose a rural generalist pathway. Can I acknowledge also the work of AMSA, who have done quite a significant investigation into this, and their recent survey found that students whose placements included parallel consulting was significantly more likely to be favourably considering going into general practice. And I just wonder if we could take that one step further and see if longer and more interactive placements in rural and regional general practice might have the same impact of encouraging our medical students to choose not just to be GPs, but GPs that head to the bush. I also want to understand what universal accessibility to bulk billing has done, and the modified Monash models are whether they are still standing the test of time. I'd like to understand how the evolution of the structure of the Medicare rebate has affected the business model for GPs, and in listening to Brendan and Norman a minute ago, you'd have to suggest that maybe it isn't evolving the way that it should be. You know, obviously we need to come up with a situation where we have the investment on specialising in general practice is in better balance with the investment and returns that one receives if you choose an alternative specialty. But I'm sure it's way more than just money that makes the decision, or made your decision to choose general practice, or for those of you who are general practitioners, or chose to go to the bush. As I've said, I'm a country girl through and through. The old saying that, you know, you can take the girl out of the country, but you can't take the country out of the girl, I think is something that absolutely applies to me. And I think that's probably why I have a particular appreciation for the focus of the challenges and the importance of ensuring equitable access for healthcare in rural, regional and remote Australia. I mean, I think it is incumbent on us as policymakers and the ones who hold the purse strings to make sure that everybody in Australia has the same access to healthcare when they need it and where they need it, whether they live in Canberra, Bourke or Arakoon. I know it's often the way health care needs to be delivered in rural and regional areas is very different to the way it's delivered in cities, but sometimes I think those challenges can even result in, you know, unique benefits and greater community benefits because of the challenges that you face. And it brings me to the theme of your conference today: bold, boundless, beyond and together. I mean, clearly by necessity in rural and regional Australia, you are innovators. The innovative ways that you responded to the pandemic, the way that you embraced telehealth, the way that you used civilian populations to be able to support you in your care work during the pandemic. And I also picked up on what Sarah said about, clinical bravery and embracing risk. It's something that I think that we should do more generally across the whole of the bureaucracy and all power to your arm, but probably by necessity. You know how to work smarter and not harder because you simply know there are not enough hours in the day to be able to work any longer. The challenges of geography within your constituency also means that you get remote medicine and the unique challenges that go with it, particularly in our Indigenous communities. And we need to listen to you, to your experiences and your advice, and make sure that we use them for practical application into our healthcare systems more generally. Which is why it's so important that that supporting the GP workforce, supporting the workforce in rural and regional Australia must be a focus of all governments. State governments must be forced to see that local hospitals are a fundamental part of the local community and local GPs should be integrated and a valued part of the provision of hospital-based care. So I'm keen also to understand how single employer models can be used to provide a better opportunity to support practice in rural and regional Australia. Recently I met with the sole GP in a little town on the west coast of South Australia in Cummins, who told me because of the contract that he has with the South Australian Health Department and his local hospital, if he wants to take the weekend off, it's his responsibility to pay the locum, and that's only if he can actually find one. I mean, that's hardly a positive succession planning for when he decides to leave the community, because, where does that leave the community of Cummins and where does that leave the communities of so many other towns around Australia in similar circumstances? But I also recognise that unless we actually can increase the total number of GPs in regional Australia or in Australia, we're only solving one problem, we'll only create a problem somewhere else. Right now, in terms of GP workforce, it seems like we're playing a giant game of whack-a-mole. So with nationwide shortages of doctors, it will always be rural and regional Australia where it's felt first and most acutely. And I must say that the recent expansion of the distribution priority areas classifications appears to be just one of these such examples. The decision to expand the priority status classifications to outer metropolitan suburbs, I think, has effectively destroyed any advantage to rural and regional Australia, which was the very reason it was put in place in the first place. And we're all and we're already seeing, real-life examples of how this expansion has pulled our IMGs away from rural communities who are crying out for GPs, including a doctor in Huonville in Tasmania, because the option of living in Hobart under the new changes meant that the Huonville community is now left without the primary care that doctor would have provided to it. The regional centre in Mildura is battling to keep many of its IMGs following the closure of a major clinic because they can now go and work in Dandenong. So whilst I've constantly said wherever I've spoken of recent times, I am absolutely committed to supporting good policy by this new government. Delighted that they've honoured the $146 million towards the commitment to workforce for rural and regional measures. I will equally not hesitate to call the government out when I think its decisions are wrong. I give you my commitment that I will be even more vigilant and even more loud where rural and regional and remote Australia is being disadvantaged by city-centric policy making. Because right now we need to be absolutely focused on ensuring that we are using the right levers so that we're getting more medical professionals to the bush, not making it harder for rural communities to access them. So, in conclusion, can I absolutely acknowledge the real challenges that you are going through, the real challenges that are faced by rural, regional and remote Australia to ensuring that the equity of access to healthcare and addressing critical workforce shortages are resolved. So I'm really keen to understand what your solutions are, and I am absolutely here with an open door and a complete commitment and promise to you that I will be the loudest and the strongest advocate for you in our Parliament. Thank you.
Thanks, Anne. Just a very quick one. Well, it's a long. Well, you're Minister for Health and Aged Care. Aged care in rural and regional communities is a huge issue. Have you turned your mind to that and what your priorities in opposition are for aged care in rural regional Australia?
Look, absolutely, and I could probably give you another 25-minute speech on that particular...
We've got two.
Yeah, okay, right. Okay, so the truncated version of it. I think that one of the things that we do need to have a look at as we move forward to implement the recommendations of the Royal Commission into aged care is to understand that there are going to be nuances in rural and regional Australia that are not going to allow us to put forward a one-size-fits-all model, which is what we have before us at the moment. I think there are some real challenges around workforce and the fact that in the response so far we haven't seen any recognition of enrolled nurses and the role that they play in our aged care facilities. I think is a fundamental oversight by what we're doing, and I think that we need to be bold, as we've said earlier, and start realising that we do need to be more innovative. You know, having 24/7 registered nurses in a tiny nursing home facility somewhere in remote Australia is probably not going to be practical, but there are really innovative ways that you can provide the same level of care, and I'm sure you'll be talking about those going forward. But I think the thing that we do need to understand, and you know, maybe it's a message to Brendan, you know, the best health minister you maybe never going to get, is that we do need to look at innovative ways that we address rural, regional, and particularly remote communities, because they are not able to respond in the same way as we are in the cities. So I think it's about being flexible and not being forced to adhere to the one-size-fits-all model that I think is likely to be applied in the cities.
Within 2 minutes, fantastic. Thank you very much, Anne. I'd like to introduce the former president of the RDAA, medical superintendent at St George, Adam Coltzau, who's going to interview the former minister, Greg Hunt. And while they're coming up to the stage, we will take questions during this period, not speeches. Okay, so I'll cut you short on the speeches, short, sharp questions so we can get through them. But first of all, there will be an interview to give you some meat to be thinking about. Please welcome Adam Coltzau.
Questions from you as well, if you...
Thanks, Norman. Thanks, everyone. Thanks for having us here today. It's great to be back. You know, ex-presidents tend to like to find other things to do and find little things that they can do to help, you know, and plus we like being in the limelight. We don't like to be off stage, and it takes a long time to get it out of your blood once it's in. I'm really happy that I was asked to do this. I didn't like the term interview. This is just going to be a chat. So this is just going to be a fireside chat. Before I start, I'd like to acknowledge traditional owners of the land which we meet today. I'd like to acknowledge the Aboriginal and Torres Strait Islander people in the room today, and I see my friend Lewis Peachy there. I'd like to acknowledge all of you for the very hard work you've done over the last few years, and acknowledge how wonderful it is to be back here in person, having a conference face to face. Greg Hunt was Health Minister for 6 years under the Turnbull and Morrison governments. Before that, he was Minister for Sport. He's been Minister for Innovation, Science and Technology, and he's been the Minister for the Environment. He's been in Parliament for over 20 years and knows the machinations of what goes on in the House. He's got degrees from the University of Melbourne and from Yale in the United States. Admittedly, it was on the carbon tax, so that's quite interesting. And during a gap year, worked in a workshop in a kibbutz in Israel. Please welcome to RMA, Greg Hunt. Welcome to RMA.
Oh, well, thank you thanks very much to Adam, and of course to Megan and to Sarah, to Marita and to Peter, Brendan, Emma, Anne. You know, I did notice that I'm in between Emma, Anne and Brendan, my old life, and the yoga session just after this, so it sort of represents the transition into a more Zen state. But to everybody here, thank you. I just want to acknowledge this group. I don't want to disagree with Anne, but she was very generous and perhaps gave too much credit to one person. The people who actually delivered the health outcomes for Australia are the ones in this room. You're the ones that helped save 40,000 lives. And to acknowledge Indigenous Australia, there's one thing that is the best acknowledgement of Indigenous Australia. With their partnership and your partnership and the work that the nation as a whole was able to do, we had the lowest rate of loss of life of any major nation with Indigenous populations through COVID. And that's what you did. So, and I think there are many ways to acknowledge Indigenous Australia, but there's no better one than that.
So, Greg, in February 2020, you and I and Brendan were in a meeting in Canberra, and you're all called out on a crisis for this COVID thing. You know, 2 years later, here we are, you've been through the worst pandemic in living memory. Take us back to 2020 and what your insights now, looking back on that, of how that progressed in February 2020.
Yeah, so look, it was a little busy, and the very earliest modelling that Brendan talked about to me and with the Prime Minister and the National Security Committee in January of 2020 was there's a new disease which is coming out of China, and we don't know whether it'll spread, but the early modelling is that this may be the greatest pandemic since the Spanish flu. And so to have a new coronavirus, and they knew that, it didn't have the name COVID-19 at that point, this means we might face a challenge we've not seen. We're prepared for it, we know what it is, and we focused, and I remember having the conversation with Brendan and the PM, and we said, we don't know how far this will go, but we will get ahead of this and stay ahead of it and run, and that may mean, in terms of the themes of this conference, we have to make bold decisions. And there was no bolder decision than on the 1st of February 2020, closing the borders with our largest trading partner, with the source of students, with the source of tourists in China, and with a potentially catastrophic diplomatic outcome. But that was probably the most important decision any of us will be involved in. And with that, what we agreed to do was to work with the medical profession and to set up the two structures of containment and capacity, flattening the curve, bringing the cases down and building the capacity of the primary healthcare system up and the hospital system, which was how the 10-year telehealth reform was delivered in 10 days. And we didn't do that to try to transform the system. We did it to protect the lives of the doctors and patients, but then we took the opportunity to embed it and make it permanent. So that was how we were thinking of what do we have to do to plan our way through it and to give confidence. And we'd rather be ahead of the game and take risks than be behind the game. And timing was everything when you look at what happened in New York, Milan, Madrid, Paris, London, comparable nations, but with catastrophically different outcomes.
So we're 2 years down the track now. What do you think has been some of the good outcomes or some of the good things that have come out of that process for you?
Yeah, sure. Look, the first thing, of course, is in terms of the lives saved. And it was the medical profession, above all else, that did that. The policy settings assisted. And those figures are conservatively about 40,000 lives saved, and numerous others who would have had terrible and ongoing health conditions. The second, though, is systemically the creation of telehealth. Now, we had a plan. Brendan and I had a cunning plan to do this over a 10-year period, working against some of the internal challenges of finance and treasury that thought that this was a wild, radical shift. So there has been radical change in the structure of medical delivery. You all do it. There's over 100 million telehealth presentations and rising every day. But the third thing was, even though there was conflict and challenge, compared with the rest of the world, our sense of national unity and purpose was stronger than almost anyone else. This was a challenge the whole world faced. We just, as a nation, came through it in a way where my judgment is we're a better nation than we give ourselves credit for. That we held together better than almost anybody else, and we helped maintain the medical profession more strongly than almost anybody else, and then the results were measured in terms of the outcomes. And so they're the structural, some of the structural elements that come out of it, but that sense of recognition of the Australian character, I think, is something that we can afford to reflect on.
So one of the things that I found that was quite good that's come out of it is that, as you said, that sense of national pulling together. But we've also seen that a lot of during that time, the red tape seemed to be cut. The nation seemed to be able to come together and make decisions very quickly, and we avoided a lot of the bureaucratic mechanisms that often hold up decisions. Can that continue? Can we continue to do that?
To a certain extent it can. So look, what was the learning? We lived in a constant state of using the National Security Committee, the Expenditure Review Committee, the broader cabinet, or a smaller contact group of the PM, myself, Brendan, Professor Paul Murphy, the Treasurer, to make rapid decisions in consultation with the sector. Classic example was when, something that you would have all experienced, the state chief health officers at the end of March closed down elective surgery. They are medical officers, but they weren't systems managers and hadn't understood that would have led to a catastrophic impact on the business models of the private hospitals, which could have literally seen 50,000 nurses and 20,000 doctors out of work. And so we were able to put in place a guarantee over 5 days for the private hospitals to underpin their viability, which made them a partner, but guaranteed their survival. You say, well, what do you learn from that? You learn that you can actually make rapid major reform quickly. It will not be as fast as that going forwards because of the consultation process required, but it can be far faster than it was previously. That's the distinction. And that's about the partnership where, whether it's ACRRM and RDAA, whether it's the broader medical sector, putting together a program for change and then working that through with government, where you bring what you believe is the best model for that change, that's the single fastest way to deliver rapid policy outcome.
So looking back over your 6 years as Health Minister, what do you think have been those biggest challenges for you as Health Minister in that 6 years?
Look, there are probably three things immediately. The first, let me speak outside of COVID. Obviously, COVID was everybody's lived experience. But the first was to understand, to have government understand that, as Anne said, health is not a cost, but it's the ultimate investment. And the classic example of that is medicines. And the pharmaceutical benefit scheme used to be seen as a major cost. And so what we did was we worked on patient cases. And by the end of that period of time, there was that transformation where the single service that was most identified with the government was the provision of new medicines, whether it was for spinal muscular atrophy or cystic fibrosis, whether it was breakthrough treatments in immunotherapy or elsewhere. So firstly, that understanding. Secondly, in terms of the long-term funding agreements for the hospital system, to take it from 100 to 135 billion, but with reform built in. And then thirdly is primary care. And there are enormous challenges, but you think of what's success and then what's to do. The primary care, putting together the 10-year plan, which is I'm really pleased it's been adopted by the new government. But what we did focus on was improving the sustainability. And you all know the challenges, but what we've seen here is that the primary care model, now we've managed to bring 5,000 new medical placements, 1,300 doctors, 1,200 nurses, 2,500 allied health and other professionals into rural and regional Australia in the last 5 years. So that's a growth of about 3.2% compound. It's double the population growth. It's not where people want to be yet, but it's interesting that the growth in rural medical practitioners has been at a double the growth in population. And so that third element of the primary care has been one of the major components, but it's also been, the unfinished business.
So you talked about the growth. That growth has come from a significant deficit. Where do you see the challenges for the next 6 to 10 years in trying to build on that growth?
So what I'd do is I would take the 10-year primary care plan and build into it as part of your consultations, but ACRRRM and RDAA, the college, working with the College of GPs and the AMA and the others, a 10-year rural health strategy. And I think that there are 3 things that you need to cover there. One is access for patients, and that's the work that we're doing with the open licensing for MRIs, but in particular voluntary patient registration. And now is that moment in history for the bold change that we're talking about. Ruth Stewart and her team are working on that. The second part of a 10-year rural health strategy would be in terms of workforce. And we know that the doctors who are most likely to work in the bush either come from the bush or are trained in the bush. So those programs for recruiting and training in regional Australia are the fundamental driver. And then the third is the question of remuneration, which is practice models. So what is possible? You're not going to throw out fee for service. I think anybody who says that is not giving you honest advice, but you can supplement it. And that's where the pooling that Anne and Brendan were talking about comes in, or the hybrid model where you can create a base fee recognising, a salaried base, recognising what you are doing as a public good, coupled with fee for service. And that moment for a partnership with the states is right now. So that 10-year rural health strategy built around access, workforce, and new models, hybrid models, I think that is the work of the next 6 months and the next 2 years to set up that long-term view out to 2030 and beyond.
You mentioned the states there because a lot of the plans sometimes don't match up. But we've seen during COVID that we can corral the states. But again, we see each day on the news the football being passed back and forwards. If that's a federal issue, that's a state issue. Can this be overcome, do you think, in Australia, Greg? Can we overcome this buck passing, or should there be one level of government responsible for health?
In an ideal world, there would be. In a practical world, there won't be. And but having said that, what is remarkable is that we were able, in the midst of the pandemic, to strike a pandemic health agreement with the states, and then to strike a hospitals agreement with the states. And these were all done in March, April, May, and June of 2020. And so how do you bring the states on board here? It has to be what's in the joint interest. So where's the mutual interest here of the medical profession, the Commonwealth, the states, and then in the centre of it, the patients? And the answer is shared support for rural services which otherwise wouldn't occur. And you know what attracts people. It's a combination of lifestyle, professional development, and where you can get that additional support for remuneration. And by having the pooled arrangements, taking the Murrumbidgee model and building that, and this is what we tasked Ruth Stewart with before I finished, to build a modular payment system where you have a combination of inputs from the states for recognising the public good and from the Commonwealth through the fee-for-service side, as well as any individual components for practice incentives, then that's what can create a sustainable model. Growing at twice the national rate, but nevertheless less than what is the ideal. And also, very few people want to come and set up a shingle and be a single, a sole practitioner in a small town because of isolation, professional development, risk. And so therefore we have to create those integrated models, and that's where that hybrid Commonwealth state block and fee-for-service funding can operate. That's the radical change.
So do you think we need, that sort of brings us to Medicare, and do you think over the last couple of weeks we've seen two major conferences on GP crisis, and a cynical person would say that it becomes a crisis when it affects urban areas, because we've been living this sort of crisis in rural areas for 10, 20 years. We're coming up almost on the 40th year anniversary of Medicare. Is Medicare broken? Is it an outdated system, and is it still fit for purpose, do you think?
I think it's evolving. So the answer is, will you move away from a central fee-for-service structure? The answer is no, is my honest assessment. Now, people may have very different views, and they're of equal merit and value. But what can you do? The key changes, as I say, are in practice, and this is where the voluntary patient registration, which was designed by the medical community, people such as Wally Jamal and Steve Hambleton and Megan and Sarah and others. So that's the first thing. That's about the relationship with the patient, and that can change to give greater focus on quality and with the incentives for payment to allow that to occur. The second big change is going back to the point of the hybrid model in the rural and regional and underserviced areas. And I agree with Anne here that there has to be a continued workforce incentive for people to go to rural areas, not just to outer metro. I think there has to be a continued differential, or otherwise the system will be gamed. And so the big changes to Medicare are the relationship with the patient, and then the practice payment in the rural areas and rural and regional areas around the hybrid model. And your vehicle for doing that is to develop that 10-year strategy, to do it in partnership with the government, and to do it in partnership with the states, who equally worry about individual small communities that may not have doctors. That's on their watch. And so that's where you have the aligned incentives and the structural changes can be made.
Excellent. Before we go to questions from the floor, and we will go to questions from the floor soon, I'll save 25 people from standing up, and I'll ask the question straight up. What do you say to the people in the room who said, when you were Health Minister, there wasn't a significant increase to Medicare, and there hasn't been a significant increase to Medicare, it hasn't kept up with the rate of inflation for the last 20 years?
Look, I respect the differing views, but the answer is that our Medicare funding went from $19 to $36 billion over our time, and that included three ways of increase. Increased number of services, increased number of items, but also the indexation. Now, the rate of indexation is a debate that's in Brendan's bailiwick now, that he and Treasury can debate that. But those three fronts saw a significant increase in that total remuneration. As I say, if you think of it from 19 to 36, a near doubling of Medicare funding, and then the health systems funding almost completely doubled right across the country. So it was the area of the fastest growth outside of the NDIS in government funding from 2017 to 2022.
Excellent. So we'll take some questions from the floor. I think there's some roving mics. While people are sort of looking at where they might go from mic, Greg, what's next for Greg Hunt, private citizen?
So I'm in theory on 6 months sabbatical at the moment around family and fitness and future. And then the future component is itself really around 3 pillars. It's one pillar, academic, working with one of the universities which has asked me to do something that's coming up shortly on innovation. One pillar, philanthropic, where I'll do a major mental health chairing role, and one pillar, commercial. And the commercial will be in innovation and new business formation, venture capital and private equity. But for now, I'm just trying to be a dad. Not doing it so successfully, according to my 17-year-old, but I'm not alone. But really enjoying that transition from the second to the third stage.
Excellent.
Thanks. I'll take a question. So can we have the house lights up so I get a better view, and maybe the key lights down a little bit? That'd be great. And there's a question up here. You could just introduce yourself, that'd be great.
Hi, I'm Deb Smith. I'm a rural generalist in Eidsvold, west of Bundaberg in Queensland. Firstly, I'd just like to say thank you for the work that you did during COVID. I've heard it suggested that it was all on you. You've suggested it's all on us, but I'd like to suggest that the big difference in what happened in Australia is that the government listened to the experts, the doctors, and I didn't see that around the world. And so my question to you is, do you think the government now can listen to the experts in primary care and find the solutions from us when the urgency is not there, I guess?
Thanks, Deb. Actually, I think you are very accurate in that big difference in Australia. When I think back to those conversations in late January and early February 2020, we really listened, and we made the pledge, the Prime Minister and myself, that we would listen. Sometimes we had to go back for a second opinion, but the advice was high quality, and that enabled Australia to have an outcome that was different. Do I think we can do that going forwards? The answer is yes. The challenge for the sector is there are so many voices in the sector. Therefore, the unified voice becomes immensely powerful. So what's the variable as to whether or not we can achieve the outcome you're talking about? Whether it's multiple voices or one voice. Now, we made the decision by listening to you to go with college-led training, and there were plenty of voices that said not to do that, and we're doing that, and that's going ahead. And I think that will be really important. But on that 10-year rural health plan, if you can work across the different groups and sectors, then it becomes almost impossible for government not to listen and adopt. If there are multiple different voices, then that makes it very easy because, there are conflicting views. But that single unified approach through that document, through that plan, that becomes almost a self-fulfilling prophecy. And you have to agree on those models, put aside the differences, but if that's done, then I think you can go to that next evolution around access, around workforce, and around practice models.
Yes. There in the middle. Yep, it's you.
The man with the microphone.
No, just the back, and I'll come back to you.
There are many microphones.
Sorry, I thought I was after someone else. Hamish Meldrum, OK Health. Look, we know that funding with Medicare follows the doctor rather than the patient, and we've got, Medicare funding to wealthy suburbs at about 3 times poorer rural suburbs. And I know you spoke about patient enrolment, but the budget funding for patient enrolment was perhaps between 100 and 200 million, where we know the funding deficit is about 2 billion for rural communities. What's the appetite for government, addressing this massive funding deficit?
Yes, I think, Hamish, the answer to that is the hybrid model. And what we set up was, there's always evolution. In the same way that there is with medical research or medical practice, there's evolution in terms of policy. And the two vehicles for you to do that are the voluntary patient registration was part of the 10-year primary care plan, but the next phase, the final phase of design, was for the coming 12 months. And out of that becomes the next thing that government addresses on the one hand. And so that's not the only way of doing this. And then the parallel thing to be doing is to be looking at the pooled or hybrid funding for the rural and regional areas. That's the partnership with the states. And so you bring those two things together and you can get significant additional funding.
But isn't that about access as well? Because Aboriginal communities underutilised proportionate to their illness. Aged people were underutilised relative to their level of illness. Isn't it more access to services as much as how you pay people?
So there are two different things that come together here. Firstly, in terms of access, telehealth has changed that, but the points of presence for rural medical support is the second element, and then the third, of course, is the cultural willingness or readiness of people to go to the doctor. So the access is a very important part of it, but the practice model will help determine whether people choose rural practice. Now, people go to rural regions for a variety of reasons: personal, culture, professional, remunerative. The remunerative is one which can be changed, but if you develop that relationship with both the patients and you have that funding underpinning, that's what's most likely to tilt the trajectory upwards of services and providers.
Lewis.
Mr. Hunt, Lewis Peachy, rural journalist, Atherton, Jilabal Gidabay man from the Jilabalagan language group of North Queensland. September 2017, Ken White promised to bring to you a request from me that you use your ministerial discretion under Section 19.2 of the 1973 Health Insurance Act to allow prisoners to have access to the PBS and to Medicare. One presumes that you decided not to. We're about to put the same question again to Minister Butler. Could you give us your rationale as to why it is that these people continue to be excluded from access, particularly to the PBS? Even Medicare would be useful too, but exclusion from PBS, and both you and Senator Ruston have made the point about how these things are investment in health, and yet a decision was clearly made to not invest in the health of incarcerated citizens.
Sure. The first thing there is thank you for the work, and I appreciate that enormously. The second is my recollection and understanding is that was one of the elements that was covered through the agreements with the states. But these things are always open for re-evaluation and reinterpretation. And you look at these in terms of shared responsibilities. This is the question. And that was one which had been covered in terms of the provision of services through the agreement with the states. And so that was the reason and the rationale at the time. But again, they're always open for evolution.
We've got a baby wanting to ask a question there, but don't understand it. Yes.
I'm Abbas.
Just go. You're on.
Yes. Thank you, Greg, for coming here for your time and the leadership during the pandemic. I think combined with our efforts and your leadership, Australia was one of the sort of envious way of managing pandemics. Abbas, I'm one of the doctors working with Virtual Rural Generalist Service, VRGS, working for Western New South Wales. My question is about the digital medical records and the fragmented way that it's set up at this stage, even within a state. You know, if I send a patient from a rural hospital to Dabo and then they ended up in, let's say, up here hospital and back to the rural community, I have difficulty knowing what happened to that patient. So the different sort of area health services don't talk to each other. And we know that a good medical...
I think we're running out of time and only time for one more question, but I think you've made your point about fragmentation.
So
of
my question
records.
is, when the government start to address that sort of fragmentation and make a unified sort of...
Probably talking to the wrong person
yes.
at the moment, but yeah, well...
No, that's all right. So the answer there is that, of course, the railway lines for a common national and lifetime personal health record were put in place. When I came in 2017, my health record was an opt-in system with about 10% of the population. We made the difficult decision for it to become an opt-out decision, which was contested at the time, but now we have 90% of the population. That is an imperfect system, but it's nevertheless the base. And when I look around the world and we look compared with other countries, there are very few other countries that have that base. So the view is that we can take what is there, make it much easier to use. If you talk about things that different practitioners have said to me, it's make it easy to use. And that's what Amanda Catamol, who's the new head of the Digital Health Agency, is doing, is trying to simplify it for practitioners as well as to lift the uptake. But it's over 1 billion items of information that have already been uploaded. But that can become where it can be integrated to the existing private software. The best and most likely prospect of having a unified national system. The train tracks are there, the uptake at 90% of the population is there, but it's the two elements of simplification and utility, and that's the work that the Digital Health Agency is doing right now. But again, as part of the 10-year plan, it's really how do we make it easy and what incentives are there for, as general practitioners and as rural generalists to be using that in a way that's not onerous, but is allowing us to put in patient information and to extract patient information.
Final question, if you could make it brief, that would be great.
3 questions.
No. God, you chance your arm.
Provider number allocation, restriction or re-evaluation, rural Medicare rebates, different to metropolitan Medicare rebates, and virtual clinics for the very isolated communities with absolutely state-of-the-art IT.
Right.
About 90 seconds.
Okay, so let me try to deal with those 3. In terms of the virtual medical clinics, telehealth now provides the vehicle, but the creation of new item numbers is one of the things that I would strongly recommend, new item numbers and new models that you put into the next evolution of the 10-year rural health plan. That is the perfect vehicle for putting forward that approach. Secondly, in terms of the rural provider numbers, that's something that we looked at, and in the end that had a dangerous feel of conscription about it and was very strongly opposed by the medical groups on an overwhelming basis. So I would be more cautious on that, to be honest. But on the other hand, differential rates for rural medical rebates, we obviously put in place the tiered bulk billing rates recently. That's a modest increase, I don't want to overstate it, but it provides a pathway for doing it on a more sustained basis. And that is something, when you tier through the different modified Monash regions from 2, 3 right through to 7, where the further out you get, the greater differential you can put in place. That, I think, is equitable, reasonable, it's sustainable, and it's desirable, and would be one of the significant next wave of reforms that you may want to consider putting forward to the government.
Could you please join me in thanking the former Minister Greg Hunt and Adam Coltzau. The executive producer of 7:30 must be regretting employing Sarah Ferguson when Adam could have been there. That's the end of the first plenary. Don't jump up yet. The morning tea is in the exhibition hall. The morning tea poster session, please have a look at that. Is in the foyer. After morning tea, there are 8 concurrent sessions to choose from, and a pre-lunch yoga session. Did I hear Greg Hunt saying he's going to that? I'm not sure. In the Wellness Centre. Lunch, the inaugural lunch, and learn silent disco style, I don't know what that is, at the exhibition hall. And today's presentation will be from Amphit on practical tips for effecting behavioural change both in others and yourself. Please enjoy, and we'll see you at the next plenary. Thank you.